Thanks, Sarah. That was really great. And so we've had four very different perspectives. We've already had a little bit of disagreement and some debate. And we're quite interested in throwing that open to the floor. Here we go.
This is a question from the online audience, Martha Turner. Is there a risk here that we're simplifying all cognitive complaints into dementia or not dementia, i.e. FCD? Those of us not working in memory clinics frequently see and treat cognitive complaints which are not dementia, i.e. those resulting from pain, fatigue, mild TBI, depression, health anxiety, misinterpretation of cognitive lapses and so on, and use different treatment approaches accordingly. Is there a risk that by calling all of these things FCD, we lose the valuable diagnostic categories and treatment pathways we've developed to date?
I answer that. Yeah, it's a good question. So I think the way I think about that is that I think that all of the things that were listed in that question, the cognitive symptoms in all of those contexts should be understood as functional. And that's why I think the unitary functional cognitive symptom or functional cognitive disorder construct is very powerful, because it gives this explanatory model that we can use in a variety of settings. Because it turns out in our current moment societally, cognitive symptoms are just incredibly common. And that may change over time, but right now it's like very, very prevalent. The issue is that what you've got to, I guess, what we all do in practice is say, well, what is the primary issue that this patient is presenting with? What is the number one thing that they would like us to try and fix in their lives? If it's pain, then we're not going to say you've got functional cognitive disorder. We're going to say you've got primary pain disorder, and what you need is a set of treatments for your chronic pain. So I think I think we've got to personalize it. The lead we're dealing with, I think the way I see it, is this sort of multi-system disorder, but the actual diagnosis, the label we give patients, and the treatment path they go down will depend on what the lead symptom for them is. And that's why Norman, I think, when he said that, oh, Jeremy's just now decided it's all depression, I think that isn't what I think. I think because clearly, if you say to people with functional cognitive depression who've got, mildly abnormal PHQ-9 scores, like the patient that Sarah described, you say, well, you're depressed, that has no face validity to the patient, and that's not a personalized diagnosis or formulation for them.
Yeah, and maybe I can add something to that we realize that actually people with depression and anxiety, as Norman presented, they have a certain pattern of cognitive symptoms. But sometimes we see patients with clear-cut anxiety and depression, and besides that, they have an additional element that is what we would call then a functional cognitive disorder. This is not applicable to all patients, of course, but I think like Jeremy was alluding to it, and I also spoke about that in the presentation, that it's somewhat a transdiagnostic concept, this framework that allows us to kind of group these people and actually recognize that these people were neglected before, and they were just told, well, you don't have Alzheimer's disease, so off you go, you don't have dementia. But then there was no attempt of like actually personalizing treatment and understanding better what they had. And nowadays, and there are a few studies, actually, we couldn't go into that in detail, but for example, there is a study by Rowan Boom that he clearly describes that there are groups of people with FCD, with depression and without depression, and they have similar complaints and similar cognitive performance. And then actually, if you treat the depressive component, then you still have to address the functional cognitive disorder component as well. And in the patient testimonial, I also showed, it was very interesting because she had a multitude of complaints, including fatigue and pain. And after doing the treatment, which we would apply to many different types of presentations, after doing the treatment, her functional component improved. So she was no longer doing the introspection process about her memory and the concern, but she still experienced sometimes fatigue and cognitive complaints that she recognized were linked. So, but it is, yeah, like we said, a developing idea.
We have just somebody up at the back. Is that okay? So also all the people at the back that have been really silent, remember you're allowed to speak too.
So when I was a trainee, we had the concept of a pseudo-dementia, and everyone thought that this was a really important concept because firstly, they were responsive to antidepressants in a proportion of cases. But secondly, there was a real need to recognize that a proportion of those would go on and develop a true dementia. Oftentimes it was in subcortical or executive dementia, which might explain part of the reason for the inconsistencies with cognitive performance. How does your FCD depression overlap? And the reason why I say that is because in Parkinson's, for example, you'll develop depression oftentimes many years prior to the development of Parkinson's. So the neuroanatomical changes, the neurochemical changes, might precede the motoric changes by quite a marked amount of time. So I'm struck by your thing, Jeremy, where you sort of followed up for about 4 months. And actually, you might need sort of 3 or 4 years.
Yeah, maybe I'll answer this question. Certainly, when I did old age liaison psychiatry, we used to encounter depressive pseudo-dementia quite frequently, and it just doesn't look anything like FCD. I don't really worry that someone coming in with FCD memory complaints has actually got pseudo-dementia. Sometimes people have been told they've got pseudo-dementia, and that can be a bit unhelpful, and you have to sort of unwind that whole thing. But really, someone with depressive pseudo-dementia is moribund and needs ECT or some good doses of antidepressants and things. I just don't think they're overlapping at all.
I mean, David, if your question was, are we missing people who may be in the very first stages of dementia? No, that wasn't the question. Okay.
Sorry. The question is, presumably the diagnosis is heterogeneous, and are we assured that there isn't a proportion of those whereby there is more of a biological element to it? So I take your point, Norman, the majority might be like that. But do we think it's conceivable? And if so, how would we recognize it? Because part of it would presumably be follow-up.
Yeah. I mean, my understanding, and others on the panel, maybe Veronica knows this literature much better than I do, is that where patients' FCD cohorts have been followed up longitudinally, what we see is the diagnosis is robust and stable, just as it is with FNDs in general. Obviously, there will be the occasional misdiagnosis in the FND clinic, just as there is in an organic neurology service, right? So we see that. But I think it's a pretty stable diagnosis over time.
And just to mention, I suppose there's a possibility for some mild brain injury being a seed for the functional cognitive disorder. But I'm aware that Steve Kemp over there. Oh, you got a microphone. Yeah. Go ahead. Sorry, Neeraj.
Hi, thank you very much. Excellent talks. I've got 2 questions, one about the concept and one about treatment. So in terms of the concept, if we are taking anybody who presents with cognitive complaints and consider, if we rule out any organic problems, and if we consider them as functional, should there be some kind of diagnostic threshold? And can we create some kind of iatrogenic harm by diagnosing people with a condition when something might be rather mild or a reassurance might be needed? So that's one part of question. And I think we got to consider that, because the more label we create and more we label people, there is likely to be harm associated with that. But the second part of the question is, it's very hard to engage people in treatment. And I think Sarah referred to that. And I think it's well and good about talking about all of these different elements. But I think the biggest element is getting people on board, getting people to understand and accept. And I was glad to see Sarah talking about 6 sessions of psychoeducation, because quite often that's what is needed. But if we are saying that anybody in primary care should be treating this, that's not going to happen. There will be huge variability in the messages we are going to give people, and then they are not likely to accept the condition or its treatment. Sorry, there are too many things there.
Also, can I just say, we're not allowed to say organic or non-organic unless there's any actual cyborgs in the audience. So, just remember, it's all organic. Ooh, sorry, Veronica, did you? Veronica, did you want to answer that? Because you've actually made a diagnostics checklist, haven't you?
No, yeah, I think I can answer the first question very quickly. So it's one of my last slides, actually. I think you made a very good point there, and we also defend that. It was actually the reason for us to do this panel, these talks was exactly the same doubts that you were raising there, because we don't think we should call all these patients FCD. And like I said, there is a risk for this to be just like a big box, or where everyone that does not have Alzheimer's disease has FCD, but this is not what we are defending, and that's why the positive diagnosis then comes into mind. And like I said, if they have clear like migraine, dissociation, sleep apnea, pain, fatigue, menopause related brain fog, all those things, they should be treated individually. Yeah, I don't agree as well that patients with a lot of different diagnoses and problems should receive another label. Just another extra diagnosis that they don't need.
Yeah, Jason.
Yeah, just very briefly, Niruj, Jeremy presented the how many people are going to memory clinics and with this problem. It is a real problem in the sense of what do you do with them, and actually one of the reasons Sarah and I developed ACE as ACT as a very brief online intervention was there's psychoeducation, it's light touch, it's the kind of thing that a memory clinic would be able to deliver actually, and then discharge people. So I don't think just a bit of reassurance is enough, but reassurance with and explanation with the extra bits should be.
Thanks. So over there, Steve Kemp.
Thanks, Niels. Yeah, my question's about.
Then we're coming to Boyd. I'm so sorry.
And then Boyd, and also Alan has caught the eye of the.
Shall I go next?
It has to be fast.
Yeah, I'll try to be quick. My question's about where we are with the concept of internal inconsistency, the way that's been characterized and the emphasis placed on that as a core defining feature of FCD. Within neuropsychology, there's an emerging young literature on intra-individual variability or dispersion, and we know from that literature that we can measure that, and that high levels of dispersion, for example, are associated with white matter abnormalities and maybe early precursor signs of AD. So that's an emerging literature on dispersion and variability. And also within neuropsychology, we've got what's now an established literature on non-credible responding in terms of inconsistency. And we know, for example, that non-credible responding is in itself inconsistent across domains. So the question is, to what extent the concept of internal inconsistency as it's a core, as it's been presented as a core feature within FCD, to what extent it's linked in with those emerging bodies of knowledge from neuropsychology, or whether it's been a bit uncomfortably separate.
Oh, I'm so sorry, we're going to have to go. Go. Right, okay, so what was that?
Let's get several questions.
Oh, let's get several questions, apparently. Okay, right, so that one, and then one here, and then one there, and one there. Okay. Okay.
But shall we deal with...
Somebody, okay, I keep being told that, so we go.
Maybe I want to hear from Professor Copeland because
I think it might be
I
Professor.
embarrassed him in public. I want him to have a chance.
Yeah, thank you.
Oh, there you go.
Now, in my service, what we saw a lot of patients who on quite extensive objective testing, they did fine, but they had subjective concerns. And we then asked, are they depressed? Have they got an anxiety syndrome, PTSD, hidden substance or alcohol misuse? Or is there a marital crisis, a financial crisis, an employment crisis? And that accounted for the vast majority of these cases, could be tackled and treated. There was a small group left who I called, and still prefer to call, subjective memory or cognitive complaints. Now, Norman, question for you. You seem to have turned that logic upside down. You're saying we've created this thing called FCD, and surprise, surprise, some psychiatric syndromes may at least partially, inverted commas, mimic our new syndrome. So the question I have for you as a philosophically inclined psychiatrist is the title of the symposium. What is the function of FCD? And for Jeremy, my question is this. In the abstract, you have written functional cognitive disorder. No, that's not yours, right?
God, what have I done?
Yeah, functional cognitive symptoms should be considered the most likely cause of subjective memory and other cognitive complaints. I want to ask you, is that really a causal statement or is it a tautological statement?
Shots fired. So we're making notes of these, and we'll be summarising them. And well, we have to keep track because there's lots of questions.
So if I talk quickly, maybe we can get 3 questions in. What do you think? So thank you very much. Obviously, Jeremy's being uncontroversial as usual, and it's very good that you got lots of questions. My thing is, I think there's I think doctors and clinicians like binary diagnoses. They like, this is heart attack, this is some other kind of chest pain. And clearly this is one of those things, as FND and other things are, which is not binary. And so that's where our problem lies, I think, that we try and keep on putting people into a box, and that's difficult. So if we accept there's a continuum of symptoms, and there are some people who have lots of other causes for the memory complaints, and there are some people who are just overly attentive to the memory complaints, how would you then treat the people who are seeing the GPs with these memory complaints? Because clearly, the GPs have got MCI as a diagnosis, and Jeremy has said, well, they shouldn't have that as a diagnosis. They should have FCD as a diagnosis. So what I would suggest that in 2 years' time, the FCD diagnosis in GP land will be really high, but they still won't have any treatment. That's my question. Thank you.
Well, okay, let's pause it there, and Alan will have the next question after. No. So 3 questions is enough, I think, for the panel, and then we'll come to Alan after that. So the first question was about internal inconsistency, and that's for the panel.
Yeah. So how do you define internal inconsistency? And do you think it's part of structural issues?
No, I mean, this is the reason for this debate. I think I really welcome this comment. I wasn't involved in the original diagnostic criteria that were proposed. I mean, this is not that definitive. So this was just a proposal to try to, again, categorize these symptoms. And like we were trying to show, we are looking for better biomarkers and better signs that can actually help us identify these populations. So if there is something in the neuropsychological field that helps us in that, I mean, it would be very much welcome.
Veronica, I'm such a bully. Wait a minute. Did you not say that you've got 91% sensitivity with your checklist? That is the thing. Like, I don't, what's on your checklist?
So, I mean, probably some of you have seen. So, like I said, the checklist was made based on evidence from the literature. So we were looking at studies since the 1950s up until now. There's a lot of work done by Andrew Lardner, for example, and other people that were pioneers in identifying these signs, things like La Maladie de Petit Papier, attending alone, all these things, and also qualitative data from neuropsychological performances, and people all over the world. So even in most of this work in the neuropsychology field comes from Canada and US actually, and they found that those things that I was showing, so qualitative performance is probably way more important than the neuropsychological objective performance as we used to call. But this doesn't mean that they are exclusive. So anything that helps us is welcome. But yeah, in the checklist is mainly clinical data, including neurobehavioral signs. So the way people approach the tests, linguistics, behavior, and the nature of their symptoms. And one thing that is interesting, for example, when we compare FCD and ADHD, like Norman was alluding to, is that, for example, patients with FCD, and this is one item of the checklist that got stronger consensus, people tend to remember their appointments with their doctors in a lot of detail. So they remember everything. They know the doctors they went to in the past, what kind of tests and questions they were posed, so what kind of medication they've already done, and they describe all this to you in a lot of detail. Whereas when we look at patients with ADHD, they were actually completely distracted during the appointment and daydreaming. And I had a colleague of mine from psychiatry saying they are counting and looking at the shape of the clouds outside the window. So then they are not able to report later what happened in the clinic. And so it's all about these subtle clinical signs that we try to compile. in this checklist. And yeah, it was validated across 8 different centers, so different approaches as well, different models of working. And
I'm so sorry, I'm bullying you. We're moving on. Keep going, Norman.
Just very, very briefly on Stephen Kemp's question, I think you're talking about sort of spiky neuropsychological profile, whereas we're talking about really quite gross inconsistencies between what you're seeing neuropsychologically and what you're seeing clinically. So I think, and actually, that's a kind of you're looking at the picture on the whole, all the clinical features. But there's something about this inconsistency which is actually getting to the kind of cause of the problem. And I think this is where I'm talking to Mike now, is that actually this inconsistency is somehow causal. And it's not just what goes on in depression and, you know, your memory, you get memory lapses and whatnot in depression. There's something about this inconsistency, this overfocus and catastrophization, which is quite distinct. I'm not saying it's only happening in FCD. I mean, it's clearly happening in FND as well. You know, like I've overly focused on my walking, on my gait, and so suddenly the gait completely collapses. That's the kind of inconsistency, and that's why I think it's a bit different. So yeah. Anyway, Jeremy, you've got another.
Do you want to come to?
Well, I really should.
Yeah,
I mean,
you better,
so I mean, just let's in reverse order on the subject of treatment. I think that it remains to. My contention would be that people with mild functional cognitive symptoms in primary care can be managed with psychoeducation and other things that GPs can access. So that's a contention, which is why I don't think that patients with what I regard as mild FCD need to come to clinic. But that's probably something we ought to test in research. Now, to come to Mike's question. So I think the difference I would make between the term subjective cognitive symptoms or subjective cognitive impairment and functional is that subjective is purely descriptive, right? It doesn't have any explanatory model associated with it. Whereas by using functional, we are then tapping into the whole science of functional neurological disorder, which has developed significantly over the last 20 years with all of the models that Sarah showed. And I also think that, you know, if you say to someone, well, you've got a subjective cognitive symptom, the patient might say, yeah, thanks. I mean, I knew that already. I mean, so I think I'm a defender of the concept of functional neurological disorder in general, and I think it applies just as well in the cognitive domain as it does in motor or the seizure domain. I think it's absolutely valid, and it gives us it's a very, very powerful explanatory model.
Now.
Does someone say here? Oh, yay!
I think we should maybe go on for a few minutes, if that's all right, just to finish the debate, because we're close. Boyd's question hasn't been addressed, and we have promised Alan a question. So
This is the birthday boy.
well, I'm not sure we'll have time for Stoyan.
Okay, but this one, so Sarah, you have to answer this. Is that okay? Whatever it is.
So Boyd's question. Boyd's question was about the continuum of this disorder and what GPs are going to say. I think we've sort of covered it a little bit.
Yeah.
But
we'll go with Jeremy. But I think Sarah obviously gave a really good account of how to treat what is quite clearly a functional cognitive disorder. I think there are lots of functional cognitive symptoms, and I think it's a continuum, which is what I was going to say. And if you're leaving the GPs to make a binary diagnosis of, well, you say you've got memory problems, therefore you have functional cognitive disorder, which is what Jeremy has told me I have to say, and I'm going to send you to iTalk, who will say, oh, I don't know what to do with this, then I think you end up with the same problem as you have with MCI. So I guess I think it's really interesting about the continuum and the kind of diagnostic criteria. But what's interesting is, well, how would you treat these people effectively? Make sure that actually all those memory problems dissolve like they did with Sarah's excellent treatment.
I mean, I think the setting was quite important in terms of getting patient buy-in. So, yeah, I mean, it's not going to work if you say go to a local IAP service and attend a group. Like, that's just not going to work, I don't think. But if it's, you know, in a memory service, or it's in a neuropsychiatry service, or it's in a neurology service, then I feel like there's that validity. You're taking my symptoms seriously. And then you can kind of get past that to other things is really it in a nutshell, I think. Yeah.
But I think that's what Jeremy was kind of.
So we've all agreed at least one neurological appointment, and then you go to there. Ta-da.
And almost that.
Then you-
We've got we've got time to hear the birthday. Grant.
Part of my question. Just one quick point on that definition, which Harriet Ball was the lead author on. It's not just about internal inconsistency, it's also about persistence over time and about severity causing occupational or social disability. So it has to be interfering with your life. But the question was, you were talking, Jeremy, about your screening and performing well on cognitive tasks. You can be pretty confident it's not going to be dementia. But a large proportion of people with functional cognitive disorders actually do quite badly on cognitive testing, whether bedside cognitive testing or psychometric testing. But of course, I think the profile's slightly different. And Veronica's heard me banging on, for instance, about if there's deficits in praxis, start worrying. But my question is, from each of the panel, quick, what's the one test, if any, you'd sit there and think, ooh, this makes me think this isn't actually functional?
So look, Alan, actually, if you look at our 2018 paper that you let me publish in JNMP, the evidence is that people with functional cognitive disorder actually at population level perform normally on canonical neuropsychological testing. So I think the evidence for that at group level there's something that of course but there will obviously be the odd individual who for whatever reason underperforms on a particular domain. Fine. What do I go on? I mean, the thing that I've learned as a dementia neurologist over time is listen to. I mean, it's a slight cop out, right? Is listen to the family, the people who come with the person. And Andrew Lana showed a long time ago in his service in Liverpool that people who come on their own to a cognitive appointment have a very low likelihood of actually presenting with having dementia. And so, if people come with someone who is worried about them, in my book, that's not FCD.
Sarah, what about you? What's your warning?
No, I'm not involved in diagnosis. I'm not particularly interested in that.
You're allowed to skip, but do you ever get?
Yeah, but I mean,
DBs.
I mean, I guess in my settings I tend to work. I'm quite lucky. People have seen lots of doctors, so it's sort of generally quite reassuring. But yeah, sometimes I might have someone in private practice who hasn't sort of seen a neurologist, and I think, oh, and I kind of go through things mentally and think, oh, maybe they should be checked. But yeah, I think the diagnostic checklist is really useful.
Okay, good, lovely. Norman?
I'm having a moment. I just can't think of one question or one sign that would. I mean, to me, it's always it's the totality of the clinical picture. Sorry.
My one was the same as Jeremy was alluding to, and it's what our research also showed. So and other people as well in Switzerland have been researching the same. So this concept of metacognitive awareness, and if patients overvalue their symptoms, this is probably like a functional cognitive disorder. But if the person is actually okay with the symptoms but then has some inconsistency and the family is quite worried, then I would be worried this is not a functional cognitive disorder. So this discrepancy.
So shall we?
Semantic paraphasias.
Very much for our panel, and it is time to leave and go have drinks.
Yeah, exactly. Thank you so much, everybody. That was an amazing conversation. Amazing.